Let us start our next session. It's about the basics of neuroimaging, a primer for postgraduate psychiatry students. Our speaker is Dr. Thomas Gregor Issac, sir, MD, DM, PhD in Clinical Neurosciences. He's the Associate Professor, Center for Brain Research, Indian Institute of Science, Bangalore. The chairpersons are Dr. C. Paneerselvan, sir, and Dr. G. Ramanujam, sir. I invite you to the dais. Dr. C. Paneerselvan, sir, has done his MD Psychiatry in Nemens. He's a director and senior consultant psychiatrist at Sneha Mind Care Hospital, Tirunelveli. He's the founder of Tirunelveli, Kanyakumari, Tuticorin and Tenkasi Psychiatric Association. Currently, he is the president-elect in Indian Psychiatry Society, Tamil Nadu chapter. He's currently as Neuromodulation Committee Chairman, Tamil Nadu Indian Psychiatric Society. He's worked as a research scientist at ECT project. He has national and international research publications. He's written Tamil psychiatry and audio books. His areas of interest are ECT, suicide prevention, and community psychiatry. Our next chairperson, Dr. G. Ramanujam, sir, has finished his MBBS in Tirunelveli Medical College and MD Psychiatry at Madurai Medical College. He has worked as an assistant professor in Thoothukudi Medical College, Tirunelveli Medical College, and Institute of Mental Health, Chennai. His current designation is Professor-in-Chief in Department of Psychiatry, Tirunelveli Medical College. His areas of interest are bipolar disorder, social biology, anthropological psychiatry, education and psychiatry, cognitive neuropsychiatry, music and brain, interested in the writings in cognitive neuropsychology by V.S. Ramachandran, Oliver Sacks, Steve Pink, Research Guide for Psychiatry Postgraduates, one of investigators in national-wide ICMR, NMHP collaboration project. He's published 6 articles in various Indian journals, given many presentations on psychiatry. Now I hand over the session to the chairpersons to introduce our speaker.
Good morning to all. Today, the Dr. Thomas George is going to speak about the basics of neuroimaging. All postgraduates should know about the basics in neuroimaging. When a patient with schizophrenia or bipolar disorder comes to you, you will ask for a blood test, a complete blood count, or you will ask for a liver function test, renal function test, and even a thyroid function test. We routinely not ask for the CT scan or MRI in a routine evaluation. But certain cases, like Dr. Migida presented in the first presentations, any patient presents the atypical symptoms or late onset psychosis, or the patient have a neurological signs and symptoms, or your evaluation for the dementia, or the patient with the delirium. So these are all the cases you should ask for the CT scan and MRI, like that. So all the postgraduates should know about what are the structural changes that are occurring in the brain, especially the neuropsychiatric disorder that you have to know. And when the exams, when they come, they give you the CT scan, MRI scan, you should identify whether it is a normal or abnormal. So abnormal, what is that? Usually they will ask for basic things. So I think that Dr. Thomas George is the best person to talk about this neuroimaging. My co-chair will introduce our speaker.
I'm very happy to introduce our speaker, Professor Dr. Thomas Gregor Issac. He did his MBBS from MOSC Medical College, Kerala in 2003 to 2009. And his PhD dissertation was on the role of renin-angiotensin-aldosterone system in cognitive deterioration in patients with cerebral small vessel disease. It was an ICMR MD PhD talent search program. And he did his MD psychiatry from the Nemens in July 2016 to June 2019. And he also did DNB psychiatry. And he did his DM geriatric psychiatry again from Nemens. And currently is working as associate professor at the Center for Brain Research, Indian Institute of Science. So he is the right person to talk about the neuroimaging. I hand over the mic to Dr. Thomas Gregor Issac.
Chairpersons, Dr. Paneerselvan sir and Dr. Ramajan sir for kind of helping me in setting the kind of correct broad step so that I can plan my foot ahead. But before I begin, I would like to ask all the PhD students who are here at the CME to kindly raise their hands. Who all are the PG students? Yeah. Okay, very good. But I see many of you standing or sitting very far behind. Because this is a radiology session, I would request you to occupy the chairs which are in the front. Okay, so maybe it's also a good exercise so that we can all get freshened up for the next session. So it's actually a great pleasure to be in this land. This is the beautiful city of Kanyakumari. And we all know the old saying that is Asatoma Sadgamaya, Tamasoma Jyotirgamaya, Mrityoma Amritam Gamaya. So Asatoma Sadgamaya, you know that from the part of, from a bad path, please lead me into the right direction. That is what the parents and the gurus and all do. For a teacher, especially a psychiatrist, somebody who is a consultant or somebody who is a professor, from what our level, we have to just lead you from darkness to light. So that is why I thought I will project this picture. And from mortality to immortality, that is definitely not in our hands. That is in the God's hands only. But let us focus on the things ahead. And I hope that this session would be of quite benefit to all of you. So I will look into the basics of neuroimaging, which is primer for postgraduates in psychiatry. So if we look at the basic aspect, let's see, there is a search for biological substrate for neuropsychiatric syndromes. Right from the time when psychiatry was actually conceived as a specialized kind of subject in medicine, people were looking to find out any organicity. And Dr. Migita has given a very kind of broad overview into how to do that. But there are certain myths which are still present among all the PG students and maybe some of the senior people as well. That is, psychiatric disorders do not have a structural pathology. I am talking to you right now in 2023, 26th of February. I am sure another 100 years later, if somebody is standing here and talking to you, he will be telling you which brain area is correctly corresponding to bipolar illness. Stimulating which brain area will reduce the symptoms of schizophrenia. We are already in that track, especially with the advent of non-invasive brain stimulation techniques. So this myth is going to get broken. Definitely all the psychiatric conditions do have a structural pathology. Now the second point, that is the second myth. Neuroimaging is difficult and only for radiologists and neurologists. So whenever a patient comes, what we have often seen is they will carry a set of films with them. And when they will immediately tell, because that is the most costly investigation, sir, madam, I have got this done also. Then we should actually look at the resident's face. He will say, okay, keep it aside. We will look at the clinical features and then we'll go ahead. Isn't it? I think I have done that. But that was when I had started my kind of career. Later, another myth is, anyway, I am a psychiatrist. Will refer to a neurologist or a physician if required. That is the next common myth. And we somehow in psychiatry, unfortunately, the part what we learned in MBBS is getting forgotten. So psychiatry, people tell, is the study of software. We are software engineers and the other consultants, other disciplines are hardware engineers. But that time is gone. A good software engineer should know which version of the processor is running. So we should also know what is happening in the brain. So this is a common myth which we have to destroy. Then one more thing. This is the most important myth, I think, which is kind of attracted all of us here. That is, I need to know some patterns. And understanding these patterns could help me in passing exams. That is definitely true because you will have spotters in MRI or CT or sometimes even PET and all. So that is another myth. But remember that understanding radiology is just a beginning. And once you are into neuroradiology, you will get so much addiction into it that you will try to actually look at corresponding brain areas in imaging, and you will order for imaging also whenever you want. So another important aspect is that just because you feel a person with minor mental illness like anxiety has come, oh, because Dr. Thomas has told, I am going to order a MRI scan. That is the biggest myth and biggest misconception. So you have to use a clinical judgment, and based on the framework which Dr. Migita has built upon, when you suspect organicity, at that time only order an imaging. That is something which is very important. The last and most uncommon myth is there is nobody to teach me. That is maybe true also to some extent, but actually it is not. Actually, people who read films, radiologists and all, when you go to them, you feel that, oh, he will shout at me, he will feel that you don't know even that and these kind of feelings. But actually it is not so. They are also willing to teach. And from whatever little bit I have learned, it's not just from radiologists, from CT technicians, MRI technicians, from MRI nurses who shift the patients there. So on the way, actually, they will teach you a lot. So why I am focusing on neuroimaging, and the topic which is also given to me is because all the cutting edge translational research on normal and pathological process in the brain for any kind of intervention, even for early diagnosis, prevention, delaying of the onset, or evidence-based interventions, or developing or giving care, is driven by neuroimaging. So that is the current trend of research. So many of you would go after your PG, maybe some will go into academic setting, and you may have to be teaching others. So that point of time, neuroimaging is going to be essential. So I thought I will take this 5 minutes for this kind of a education on things, because psychiatrists do that mostly, isn't it? Then coming to the neuroradiology in particular, we have to understand these planes. These are the coronal plane, the sagittal plane, as well as the parasagittal plane and the axial plane. Okay, so this is something I thought I'll just tell you. So whenever you see an image, in either in the CT or MRI, you have to identify what plane it is. Is it a coronal or an axial, or it is a sagittal plane? So again, a reiteration of that. The first picture is the sagittal plane, the other is corona. Coronal plane, we all know coronavirus, ring shaped, or the corona means crown. So it is cut in the how we wear the crown. So that is why it's known as coronal image. So then there is the axial image, which is the most common image. So the beginnings. So can any of the PG students identify the person and I think that's an X-ray, isn't it? So please. Yeah. Who is that? Rontgen, you are right. Rontgen, correct. Who is that in that particular X-ray? Yeah, you are right. So it is his Bertha Rontgen, that is Rontgen's wife, and this was one of the first X-rays which was taken in the history, and that is his wife's hand, which shows the wedding ring also. So this is how it all began, that a ray which was not known is known as X-ray. Good, I am very happy that you were able to identify this. This is a technique which I think the seniors here will know. Maybe some of them have even attempted and done it also. This is known as pneumoencephalography. Okay, so it was understood at that point of time that if you put some air in the ventricles, it is likely the air is more permeable to X-rays, so the other structures would stand out. So this was one of the first kind of attempts at that. And you should imagine 15 to 20 cc, that is 15 to 20 ml of air was pushed in a syringe through the spinal cord, and the patient was positioned in different way so that the air can go up and reach the ventricles. Now that had resulted in so much pain, but still it was life-saving because tumors and others could be found out. So this was how it all started, and I am sure the seniors here would know that pneumoencephalography or pneumomyelogram were all kind of things which were initially started to look at the various pathologies in the brain and spinal cord. So this is angiography. Can anybody tell who discovered this technique or who identified this technique? He is very famous in psychiatry, that's why I'm asking. I'll show his figure also. Are you able to see him? Yeah. Can anybody tell? He got Nobel Prize in psychiatry for some other discovery, not for angiography. Actually, he found out angiography, but he got a prize for Nobel Prize for another surgery known as prefrontal leucotomy or frontal leucotomy. Yeah, Igas Moniz. So Igas Moniz was actually the person who also had identified angiography but got Nobel Prize for a surgery which is no longer done and considered quite unethical. So what is a CT scan? Let's come to CT scan. So the outline of my talk would be to tell something about CT, basics of CT, show you some kind of CT films, and then go to MRI. Okay, so this is what I would be trying to do. You don't have to worry about taking big notes. You cannot take notes because we'll go fast. I've told Dr. Nurul to share the slides. Please do share this, but only in official forums because it is a very important medical thing. But we have taken consent from all the patients from whom we have got the images. So what is a CT scan? It stands for computed tomography. So it's a complex kind of representation. So it's actually based on principle of attenuation. So it is basically involves the particular X-rays only. And what happens is that the X-ray will rotate around a particular subject, and then at each section it will take a cut. That is why the cut section is known as the tomogram. And the computer will process all this together to form what is known as the CT image. Who is this person? Very good. It's Godfrey Hounsfield, who invented CT in 1971. So imagine 30 plus 23, how many? 54 years old technique. And that has kind of saved so many people, so many lives. So this is Godfrey Hounsfield, and he is the pioneer of CT scan. So the basic principle, as I already told, is X-rays are absorbed to different degrees by different tissues, like in a routine X-ray. And here in CT, one important thing you have to know for exam also is, you have to describe CT findings as densities. Okay, so it could be hypodense, hyperdense, or isodense. You understood? So higher the density, it is whiter. That is, bone is whiter. Okay? Lower the density, it is darker, CSF or water. And isodense is the brain matter. So anything of the density as brain is known as isodense. Okay? I think this is a very simple thing for all of you to know. Hounsfield units is something which you should know. For example, it is a range from minus 1000 for air, 0 for water, and plus 1000 for bone or minerals. Okay, so if you see this particular CT, you can see the bone. The skull calvarium, it looks very hyper dense. So it is whitish in color. The water or the CSF looks almost black. It is hypodense. And the brain parenchyma looks in between. You can just for our understanding, you can tell. So it's about 43 or 46 kind of Hounsfield units. And it is isodense. Okay, so this is something which you have to understand. Now coming to some calcified structures there. Can you identify the calcified structures? One near the third ventricle. Third ventricle is the slit-like thing. Below that there is a calcified thing. Can one of you tell? Very good. It's calcified pineal gland. Okay, so that is very important. So somebody more than in the second decade, pineal gland is always calcified. Okay. And what is there in the occipital horn of the lateral ventricle? Can somebody tell? Not arachnoid granulation. Something which produces CSF. Very good. Excellent. So choroid plexus. So in elderly, somebody who is more than 40s also, that also appears calcified. Okay. So just to kind of give you some understanding. Maybe my talk is very basic for some, but please don't mind. I thought that I will take it for the level of the postgraduates. Okay. So coming to the appearance, I have told you the Hounsfield units and the different densities. The more dense the tissue, the brighter it looks on CT. Any calcified structure appears bright. New hemorrhage in the brain is also bright. And water or CSF looks dark. Okay. Suppose one person is having stroke. How early can the CT pick it up? Can somebody attempt to answer how many hours? 5 hours, 6 hours, 10 hours, 12 hours. Yeah. So the current dictum is CT can pick up stroke only after about 6 hours. So that is where the MRI is having a more bigger advantage over CT, especially in acute strokes and for thrombolytic activities. So when is a CT considered? I think this is most important slide, especially for people who are working in periphery or working in tertiary hospitals, who are psychiatrists, psychiatry trainees, because when to order a CT is quite important. When you are in charge, suppose I am a doctor, I have my own hospital, I have CT machine and MRI machine. MRI gives me 5,000 rupees per person. CT gives me only 1,200 per person. Okay, so if I am a businessman, I will order MRI, which will give more things. But when should I order a CT? Just look at this. CT is much faster than MRI. So it does the study very fast. So making it a study of choice in case of trauma and emergencies. So whenever you have trauma, or whenever you have acute head injury, immediate CT is very much required. CT is cheaper, I have already told that, and it is good enough to exclude big issues. Like if there is a bleed, if there is a space occupying lesion, or if there is a big contusion, in such cases CT itself is good enough. So you don't have to do further MRI. CT is less sensitive to patient motion. So many a time people will bring to you MRIs, and when you try to look at it, you will see circular lines, you will see transverse lines, you will see some star-like artifacts. All these are artifacts, and that shows that the patient has moved inside the scanner, and you will not be able to make any kind of judgment on it. So a badly performed MRI is much worse than not getting a CT. Understood? So CT is actually quite useful, and it is kind of useful or resistant to patient motion. So that is something which is very important. And CT may be easier to perform in claustrophobic or very heavy patients. Have any of you undergone MRI? How many of you have undergone MRI? Has anybody gone inside the gantry? Okay, so I will tell you my experience. When I have got inside the gantry, I felt I want to run out from there. It was like an agoraphobia. Really, I will tell you, it was kind of very difficult. And I am sure people who undergo MRI would have understood. It's not very easy. And to be in the scanner for 1 hour, if there is some research study, it's even more difficult. So that is where CT is useful. It is helpful in claustrophobia and in very heavy patients because they have difficulty to be mobilized in the gantry, which is maybe of smaller diameter. So CT also gives a good evaluation of the bone. So I have already told. So if there is a fracture of the nasal bone, if there is a fracture of the zygoma or the maxillary bones, then CT is better. CT also allows accurate detection of calcification and metal foreign bodies. So that is something which we have already seen, the pineal gland calcification, the choroid plexus calcification, all that. And CT can be performed at no risk to the patient with implantable medical devices. So now is the place where you have people walking in with many devices. People will have defibrillators, people will have kind of what we tell as different types of implants. People will have cardiac pacemakers, very common. And now is not the time. You will see people coming with different body piercings, tattoos and all that, which is of metallic ink and all that, will have its own problems in MRI. Okay. So in such cases, CT is much, much beneficial. So this is when CT should be considered. Now how to read a CT scan? First of all, I have told about density. Now you have to look at the symmetry. Compare the left and right side of the cranium. Midline, you have to look for the midline shift. So midline shift is indicative of what? Can any of the PG students tell? Very good. It indicates that there is a space occupying lesion which is pushing one part of the hemisphere to the other part. So what is the criteria for midline shift? How much mm it should be from the center? Actually, it's a line drawn from the middle part of the CT through the septum pellucidum. If it is displaced by dash mm, it is known as displacement. What is that mm? I will give you a clue. Is it 1 mm, 5 mm, 10 mm, 20 mm? You can try. The Slido is not there, but you can try. Now it's opinion poll. Very good, 5 mm. So if it is more than 5 mm, it means that you are not dealing with a psychiatric case anymore. You are dealing with a neurosurgery or a neurology case. Okay, these are simple things I am telling for PG students. But even more than 5 mm, we still have a role. Okay, that I will come to later. Now, cross-sectional anatomy. Review the anatomical landmark for each section. You have to look where the sections are through. So, the brain tissue, gray matter, white matter, intracerebral, any lesions are there or not. CSF space, the ventricles are dilated or not dilated. Skull and soft tissue, is there any scalp swelling, fractures in the sinus or orbit? And then look at the subdural windows to see, especially in elderly or people with chronic alcoholism, to look for any blood collection adjacent to the skull, because they are tending to fall down, getting the avulsion of the emissary veins, so on and so forth. Bone windows also you have to look for any fractures in the skull, orbit and sinuses and intracranial air trappings. So that is something which is very important. So you see here, the slice thickness will usually vary, but in general, the slice thickness in a conventional CT is 5 and 10 mm in a routine head CT. But you have high definition CT machines also, which cuts even at 1 mm. Okay, so this is something which you have to see. So you have seen this particular picture and you see the transsections, the lines which are the different sections, okay, which represent the different slices which are taken. And you can see that it is not kind of in angle with the mouth. It is actually slightly in the angled manner. Why is it so? Why the CT kind of saves, or only the head part is taken and it is not taking the anterior part of the orbit and all that? What would be the reason? So reason is, if you involve the orbits also, okay, there are separate sequences for orbits also, but if you involve the orbits also in routine conventional CT scan, there is high amount of irradiation to the retina, okay, and it can also result in tumors and all that. So that is the reason it usually is taken in an angle. Okay, so this is something which is important, and it can help in identifying the different types of hemorrhages. What are these hemorrhages I am showing in this picture? It's written already. Can some of the PGs attempt? So can you try to read this CT scan, the top one? Okay, so you can look at the symmetry. Is it symmetrical or asymmetrical? It is asymmetrical. Okay, is there a midline shift or not? Okay, we may have to measure, but still with visual only we are able to tell that's a midline shift. Very good. Where is the lesion? Left or right? So whenever you look at CT, the axial plane, imagine that a person is lying down and then you are looking from the foot end. Okay, so here a patient is lying down and you are looking from the foot end. So the lesion is on the left side and the lesion is, or the brain is pushed to the right side. Understood? Yeah. So now what is the lesion looking like? Is it hyperdense, isodense or hypodense? Okay, I am getting maybe mixed responses. Okay, so hyperdense. Now one single response. Good. So it's hyperdense because it is more than the Hounsfield unit for water, that is CSF, more hyper than the brain. So it is hyperdense. And how does it look like? Okay, does it look like an idli? Okay, it looks like a biconvex shape. Okay, so it is actually extraaxial. It is pushing the brain. It is very much delineated to the opposite side. So it is an extradural hemorrhage. It's an extraaxial hemorrhage. The same thing is depicted on the right side in the picture down. Okay, are you all with me till now? I am lost, or you are lost? You are all with me? Very good. Okay, fine. So who wants to describe this now? One of you can attempt. No problem, we can all make mistakes. We are not radiologists, so no problem. That's a good thing. We can always get another opinion if required. Yeah, please attempt. So it is a CT film. First of all, you have to tell it's a CT film. Okay, axial section. Okay, and here it shows asymmetry, and there is a midline shift to the left side. Okay, good. Hyperdense lesion in the right parietal region, parieto-occipital region. Okay. Yes, biconvex, and it is pushing the brain parenchyma to the left, and you can see the obliteration of the ventricles on the right side as well. Okay, the right lateral ventricle is not well seen. Okay, so if you tell all this, and if the CT is given to you and you can tell the name of the person, Mr. Ramesh or somebody, hit by this vehicle or fell down with this particular CT film. This is a normal CT, not a kind of contrast CT, with asymmetry, midline shift, obliteration of the ventricles, as well as a hyperdense biconvex lesion, which is suggestive of extradural hemorrhage. and requires immediate burhole evacuation, there is likely that out of 10 mark you will get 7.5 at least. Okay, so please do that. Good. So it's an extradural hematoma, biconvex shaped in CT. Who wants to attempt this? Can anybody try? Try. You are getting this CT, and the patient is having some unconsciousness, and he is having weakness of the right side. So first of all, can anybody tell how many lesions are there? Is there only one lesion? Very good. So there are two lesions. Remember your forensic medicine. You have heard of an injury called Coop and Contra-Coop injury. Remember? Okay. So the accident happened where? On the first site, but in the opposite site. In the first site, it resulted in an extradural hematoma. The opposite site, it resulted in the what? Contusional. It's actually intraparenchymal hemorrhage or contusional hematoma. Okay. So EDH with opposite hemorrhagic contusion. So Contra-Coop injury in elderly. And in elderly, like Dr. Migita was mentioning, they are on multiple medicines. Polypharmacy is the rule. So they are on acetrom, ecosprin plus clopidogrel, okay, dicumarin derivatives, everything. So you should be sure that in such people, you should always look at the CT carefully. So that is important. Who wants to attempt this? I think we should call by people from Tirunelveli, then Kanyakumari, Tuticorin and Tenkasi as 4 teams and do that. Maybe Dr. Nurul can conduct a quiz next year. Okay, who wants to attempt? Yeah, please.
CT axial plane.
Very good.
Is asymmetrical.
Very good.
There is a midline shift towards right side. The lesion is on left side. It's a hypodense lesion with concave lesion as subdural.
You are right. But is it hyperdense, hypodense or isodense?
Hypodense. Hypo.
So in such case, you have a confusion, isn't it? Is it hypo or hyper? And you are not sure it's hypo because it's more than water, more than CSF. But you are not sure hyper because it is not equivalent to bone or less than the brain parenchyma also. So in such cases, the examiner will be looking at your response, what you will tell. Hypo means you will got, hyper you will get got. So technique is mixed density. Okay, like psychiatry we do. Isn't it? So you have a mixed density lesion. So it's a chronic subdural. That is the thing. So that the blood has become hemosiderin right now, and you can easily say mixed density. Then we can do that. Okay, I'm making fun of psychiatry myself. Sorry. So, but that's how we can deal with it, utilizing some of the skills we have got from communication. So we can do that. You understood, na? So it's a mixed density lesion, and there's a midline shift with mild obliteration of the lateral ventricle, and you can also say. But is that enough? Suppose you have got first class now. If you want gold medal, is there any other lesion there? Look carefully. Is it only SDH on one side? No, in this axial itself. You are looking at the left side. Please look at the right frontal also. Do you see a gap with a mixed density lesion there? If your eyes are able to pick it up. Okay, so that means it's a bilateral subdural, left more than right. Okay, that is for gold medalist. Chronic SDH, crescent shaped. Okay, I'm joking. All of us are gold medalists only, don't worry. Fine. Now, who wants to read this CT? This is easy because we have read the previous one. This is what you will get in exams, nothing more. I'm not very sure will they keep more. They may keep some other things also which we will discuss. So what is this? I have put the arrows also where all are the lesion. So this again a bilateral SDH. Okay? Yeah. Understood? So if you look at this is a newer SDH, it's not very chronic. The chronic SDH is a mixed density. Yeah. This is another thing where you have a coronal view also along with axial view. So I'll give you the history. 53-year-old Mr. X with uncontrolled hypertension, fell down while he was having food, and then he had weakness of the which side of the body? If he is a dominant handed, right? Okay, left side of the body, and which with some mild speech defects. Okay, so what would you say for this particular person? Who wants to describe the CT? So it's a hypertensive. Hypertensive people are prone to bleeds, and the bleeds are most common in the basal ganglia. There's an area called putamen, and it's called putamenal hemorrhage. Okay, so if you are able to tell this, but if you can tell intraparenchymal hemorrhage, and in the coronal, you can also appreciate a midline shift, isn't it? Yeah. So this is the lesion. It's a hemorrhagic lesion because it's hyperdense, and it's a hypertensive putamenal hemorrhage. So immediate stabilization is quite useful. Okay. Yeah. So good. Yeah. Who wants to describe this? Can try. I am showing you the lesion. It's a, what is it? It's a hyperdense, hypodense, hyperdense, hyper. It's a hemorrhagic condition. He fell down and he developed. Here there is no Kunderkoop. Okay, so that's something which you have to see. Yeah. So this I have already kind of unfortunately shown you. This is a right MCA infarct. Why do you say it's right MCA infarct? First of all, it's in the right side. Good. What else? So what all areas is it affecting? So you have to understand the blood flow or the vascular territory to understand this. So if you see, it affects the temporal region, the part of parietal region, and part of the posterior frontal region, but predominantly in the temporoparietal region on the right side. And if the patient is having hemiparesis on the other side, so this is on the right side, okay? So he is having hemiparesis on the other side, you should think of a MCA infarct. If the left side is involved, and he is along with that would have language issues also, okay? So this is something which you have to do. So who wants to describe this? Person who came acutely, he was confused, he had weakness of the right side, and whenever you are talking with him, he was not able to comprehend and he was not able to repeat, he was just muttering something. So we will, okay, are you sure ACI is also there? But more than that. So it's a large kind of infarct, isn't it? With significant edema. Okay. And so it's a relatively delayed infarct. And it's a large left MCA tertiary infarct with edema. So why edema also I will tell you. Edema is what will cause significant penumbra around the particular region, and it will kind of reduce the sulcal space. And it will cause significant headache also. Okay, because it stretches on the meninges. Who wants to tell this? I am giving the arrow also. So can you identify the region where it is? Starts with T, thalamus. So it's in a basal ganglia structure. The anterior or the dorsomedial nucleus of thalamus, which is again supplied by the lenticulostriate branches. And if you see, it is bilateral. Okay. So it's a bilateral. Usually this happens in severe dehydration in pregnant women and people who are on starvation and all, and suddenly they decompensate. And they can present like similar thing. This is known as strategic infarct. Okay. And this is usually bilateral strategic infarct. They present to the OPD like dementia. We will think they are Alzheimer's dementia, but when we actually look, we will find bilateral strategic infarct. If we don't do imaging, we will treat them with proper medications and donepezil and all whatever. But after 3 months, they will be absolutely fine. Then we have a dementia which has completely improved. We will be very happy. We will want to write a case report. That point of time, we will take the image and we will find that it was a strategic infarct. Okay. So strategic infarct should be something which you should consider, especially in elderly. Okay, so who wants to attempt this? This is another tertiary, another vascular tertiary. I will show the areas. Bilateral, occipital. Which artery supplies the bilateral occipital lobes? I'm not able to get the answer. Posterior cerebral artery. Okay, very good. So this is bilateral PCA tertiary infarct. Okay? Are you with me or I am lost? Yes or no? Little more louder. I think everybody is tired. Okay. So this is one last CT film I am going to show you. PG postgraduates, please tell. We'll find out who is there from Tirunelveli, Kanyakumari, Tutakoran and Tengashi. Who are better, we'll find out. Okay. Who wants to tell about this? Can you read the CT? People from Tirunelveli can answer maybe. Attempt. One of you can attempt. Even if you make mistakes, it's okay. We can ask opinion from radiologist. No problem. Yeah, attempt. There is no problem in not attempting. Yeah, try.
Left occipital lobe infarct,
Very good.
probably
So,
posterior cerebral artery.
don't forget to tell that it is a normal CT brain,
CT brain.
axial section, which shows an hypodensity in the left occipital region with no midline shift, and likely it is a left PCA tertiary
PCA
infarct. That's all. Okay. I hope you have understood CT little bit. Happy? Okay. Then one more CT for all of you. Maybe last CT. Yeah, this is spotter, so all of you may know. Very good. So why do you call it NPH? NPH can be told by when you are doing MBBS and writing NEET exam. But what is this? What are the criteria for NPH?
Bilateral ventricles are equally dilated
Very good.
without any cortical changes.
Okay.
Um,
What else? So I'll give you a homework. Okay. Because you may have some time when you go back home. You can look at the radiological markers for NPH. And this is in MRI and CT both. Okay. For CT, what we have known is, we have one known as Evans index. Okay. Evans index. And then MRI, there is something known as callosal angle. Okay. So just note it down. Later when you go back, you look at what happens to callosal angle, how much degrees it is in NPH, and what is Evans index. Okay? Fine. Okay. Can somebody tell what this is? Are you able to identify that this is a CT? Yes. So one of my target is done. Are you able to identify is it axial or sagittal or coronal? Axial. Very good. Excellent. Now what else? Is it normal or abnormal?
abnormal.
Abnormal. Very good. Okay. Why do you say so?
No clear-cut demarcation.
Okay.
of
Sir is telling
gyrus.
it's mixed density. Sir put the same trick on me. But that's right. Because we are not able to identify the gray matter, white matter here. It looks like a crumbled shut has been ironed out. This is known as ironed out brain. And this is suggestive of edema, cerebral edema. When we are not able to make out anything, sir, you have to buy some time. Sir, just let me see, like that you have to start. It looks like, so when you tell CT, axial and all, you are actually getting time to rehearse in your mind to tell the next sentence. So that is one technique I'm telling you, like don't tell anybody else. But this is one technique I'm telling you. Whenever you are asked something, don't tell immediately, I don't know, sir. Okay. I'm sure none of us will do that because we have already trained in psychiatry. But still, if you are telling, sir, this looks like CT, this looks like axial section, by that time you should be thinking, it looks like there is no great white matter differentiation. So it looks like a cerebral edema. Okay, simple. So no differentiation of sulci or gyri. So CT venography is also useful. Okay, especially when you suspect something known as cortical venous thrombosis or deep CVTs like that. So I am just putting this, may not be asked for you, but this is especially important in South India where postpartum people will develop seizures or deep vein thrombosis and then develop seizures and come to the emergency or even to the OPD. You have to think about these aspects. That is, there is deep vein thrombosis or which are spread up and resulting in a cortical venous thrombosis. Typically, they come with fever, multifocal seizures, and altered sensorium. Okay, so in such cases, CT venography will help us in finding. You can see the transverse sinus, and you can also see what is known as an inverted delta sign or an inverted lambda sign. Also, people tell. Okay, so this is something which is quite important to know in deep vein thrombosis, which has gone and caused cortical venous thrombosis. So CVT is the diagnosis. Okay, so I have some time, isn't it? That's all. Okay, fine. See, so okay, fine. Let's see. So before we go into MR, I want all the PG students just to stand up 1 minute, stretch yourself and sit down. So CT is very tiring. Okay. Now we are going to MRI, which is even more tiring. Free. Okay. Okay. Yeah. So only the PGs. Teachers know it. Okay, fine. Thank you. Thank you. So MR, come to MR. MR stands for magnetic resonance. Okay, so it's a tool where we use a magnetic field created by giant magnet and we get 3D images. That is what. All of us have heard about MRI. It's a very, there are more than 5,000 MRIs in India as per the whatever the data available till last week. So these were the people who actually invented the principles behind MRI. They got the Nobel Prize. There were other people whom I am not quoting here. But Mansfield and Lauterbur were the persons who actually kind of gave the principle that it can be utilized in imaging, especially for humans. So when should we use MRI? So MRI does not use ionizing radiation, so it is preferred over CT. It's non-invasive. And it has a greater range available for soft tissue contrast. So you can see that in CT we have to look at the Hounsfield unit and then come up with a contrast in a normal CT. And unless you give a iodine based contrast in CT, we are not able to differentiate the soft tissues, whereas in MRI the sequences itself help us in giving good contrast. And MRI window can be easily removed and you can get good contrast images. So what happens inside an MRI? So people who go into MRI would have realized that when they are lying in the MRI, you will get a coil over your head, okay, and you will get hear some big sound, so they may give some earplugs also. So there's a primary magnetic field, which is a B0 field, which is created by a superconductive magnet. So you would have heard of terms like 1 Tesla, 1.5 Tesla, 3 Tesla, like that. This means the B0 or the strength of the magnet. The more powerful the magnet, the more better resolution images you can get, because the primary magnetic field is very strong. So the protons will, or the hydrogen atoms in the body which are present abundantly in the water would actually align properly. Okay, so this is what is known as the particular aspect of B0 or the primary magnetic field. There are some places where there is 7 Tesla magnet. So in under 2 years, AIIMS will have the 7 Tesla magnet. They already have 7 Tesla magnet for animal studies. So that is something which we have to understand. Then there are gradient coils and there are radio frequency coils which are put around the head or the particular area of interest. And when these magnetic fields are changed by giving radio frequency pulses, the signals are very simply, I am telling, the signals are got by the detector and they actually are processed in the computer and we get the final image. Okay, so MRI physics itself is a big area. If you are interested, maybe we can discuss it later. So the two most common types of MR images are, have you heard of T1 and T2 images? Okay, so T1 images help to look into the anatomy and T2 images help to look into the pathology. So these are principles. I am not going much into that, but you should realize that it is based on what is known as TR and TE. TR is the repetition time, that is, I am giving a radio frequency pulse now, the magnetic fields are shifting and then I am again repeating the radio frequency pulse. So in between the time, that is known as the TR interval. And T is the time to echo when I give a radio frequency pulse and I am getting a high energy pulse return. So that is known as the echo time or time to echo. So in T1, TR and TE is short. And in T2, TR and TE is long. If somebody asks you, you can at least tell that. T1 waiting, TRT is short, T2 weighted, TR and T is longer. So what is bright and dark on T1? This is something which would be helpful. So look at T1. First of all, in a T1 image, you should understand it's a T1 by the gray matter appears gray and the white matter appears white. Okay, and CSF appears black. So in MRI, unlike in CT where we do density, here we use the term known as intensity. Okay, so signal is either hyperintense, hypointense or isointense. Okay, so that's one thing. So if it is bright or dark on T1, you can see fat could be bright, white matter is brighter than gray matter. Okay, so in T1, gray matter is gray, white matter is white. CSF is dark. So what is bright or dark on T2? CSF is white, ulta. Okay, gray matter is more whiter. Okay, and white matter is more grayer. In other words, you can see that water is bright or CSF is bright, blood appears bright, white matter is darker than the gray matter. So that is a T2. Okay. And this is the different structure. So whenever you are going for a proper MRI discussion or you are going to go about understanding MRI, you should know the surface anatomy and the neuroanatomy very well. So I am just giving you this picture, which I am sure Dr. Nurul will share across. So these are different normal brain anatomy, which I am not going in much detail. This is a very important slide. So we have structural MRI, we have diffusion MRI, we have functional MRI, and we have spectroscopy. Okay. So structural MRI is when we look at the tissue composition. So it looks at T1, T2. There is another sequence which is of importance known as flare. Have you heard about flare? Yes, very good. Fluid attenuation, inversion, recovery, wherein the CSF signals are inverted. And then there is diffusion, which is especially useful in stroke. So diffusion can pick up stroke within 30 minutes. CT can pick up only after 6 hours. And fMRI, where more of the studies, especially on psychiatry and neuropsychiatry, is being concentrated. And something known as spectroscopy, especially in developmental disorders like autism, ADHD spectrum, and all that this particular MRS is being also used. Okay. So the workhorses for a particular MRI, the different sequences are T1, T2 and flare. And there is diffusion weighted imaging. So for our level, for example, if you are going for exam, you will get maybe a patient with acute stroke and you will get a diffusion image. Okay. In diffusion image, DWI, diffusion weighted images. So anything which appears white is diffusion restriction, DWI. So W is there in the diffusion. Okay. And you will have another sequence known as ADC, apparent diffusion coefficient. Whereas ADC, D is there. So the particular area where there is diffusion issues or a diffusion restriction, it will appear darker, apparently darker in ADC. Okay. So that's one kind of memory trick I am giving you, which you can use. So here you have a diffusion weighted image. You can see it appears white, okay, or hyperintense. And here ADC, which shows it is darker, the same area. So this is the left MCA infarct. What is this sequence? Very good. It is known as diffusion. It's another form of diffusion image, diffuse or tractography or diffusion tensor imaging. Okay. So you have different colors like red is there, red, green and blue. Okay. Red shows the transverse direction of the water. So it looks based on the concept of fractional anisotropy. So if somebody asks you, you can tell what is fractional anisotropy is nothing but how the water molecules move inside the axon. Okay. So red means transverse, green means antero-posterior kind of arrangement, and blue is more of craniocaudal. Okay. Now I will give you, so I have already told this, so I will not go into much detail, but muscle MRI is also gaining popularity, especially because of DMD, as well as looking at neurocysticercosis, which actually favors the muscle. And this we have already gone through, but hemosiderin is also checked by microbleeds by another specific sequence known as susceptibility weighted imaging or SWI. Okay, so this we have already gone through. This is a small revision. And we also have what is known as gadolinium based contrast in MRI. So that is something which also has been utilized as a contrast material in MRI. So flare, I have told you about flare. So flare will actually, what flare will do, T1 and T2 you can see. Flare is nothing but a T2 image, but it will invert the sequence, or it will subtract the water CSF signals. So in efficient you will get a T2 which will look at the pathology without CSF. So the CSF can also cause artifacts, it can cover up the different forms of stroke, white matter changes, so that can be prevented by having a flare images. So these are some of the typical MRIs which can be kept in the exam. One is ADEM. What is the full form of ADEM? Yes. So chairpersons have told. So it is encephalomyelitis, and it affects both gray and white matter, and it is large widespread. The other illness is the adrenoleukodystrophy. This is known as what is known as the garland sign. So if you look in the posterior aspect, it looks like somebody is going to put a garland on your head. Okay. So it's a typical sign which is seen in adrenoleukodystrophy. There is an entity of small vessel disease which is autosomally dominant, known as CADASIL. There you can see significant white matter changes, predominantly in the claustrum and insula. Then there is a CNS lymphoma, again a mixed density lesion. This is what is known as a high-grade glioma or a butterfly glioma. It looks like a butterfly, isn't it? It actually has gone over the splenium to the other side. Then there is HIV-associated neurodegenerative disorders where you can see white matter changes as well as gross atrophy. Then there is low-grade glioma. And then there is METS. So METS you can see a mixed density which is isocentric lesion also with a proper capsulated kind of lesion in between. And in migraine also, post-migraine if you are getting MRI, you can get some artifacts, especially white matter changes. In multiple sclerosis active also you can see the white matter change. So all these are different forms of white matter changes and the spectrum of white matter changes which I am representing in this particular slide. The most common is a small vessel ischemic. So whenever you see MRIs of old people, you may see lot of white matter hyperintensities. Actually 90% of people above the age of 60 are supposed to have white matter hyperintensities. Not all of them may have dementia also. So this is something you have to bear in mind. I am not going to in much detail, but this is the summary of what I have told. Then I have told about T2 star, or another better image is SWI sequences which actually shows microbleeds. Now CT we have already gone through. MRI is actually done mainly for diagnostic imaging as for research purpose. So these are different pathognomic signs. So there are some signs. When you hear that, you know that this is this illness. For example, if the ventricles are affected in a neurodevelopmental kind of patient with a neurodevelopmental disorder, then you have what is known as a pancake brain. It looks like a pancake with hollow prosencephaly. That is the entire ventricles there is undivided. It is a characteristic feature of kind of neurodevelopmental disorder. And they may present with seizures also. This is what is known as the eye of the tiger appearance. You would have heard of it in NBIA, neurodegeneration with brain iron accumulation, previously known as Haloverden-Sparks. Yes. So Haloverden-Sparks, the name is not used. You know why? Yeah, because he was involved, he was with the Nazi and he had exterminated a lot of Jews. So for that ethical purpose, actually the name is changed to NBIA spectra. And there is a Joubert syndrome in children where they will have oculomotor apraxia. And they will have what is known as the cerebellar peduncles. You can see it's very long. It resembles that of a molar tooth. So it's known as a molar tooth sign. So then this is also seen in children. Metachromatic leukodystrophy, they have the tigroid pattern. So you can see that it's a patch. Entire white matter is affected with some patches in between. It's known as tigroid pattern. And in a young child or in 10 and 20 years of age, you should be suspecting this. This is the Mickey Mouse sign which we are seeing in progressive supranuclear palsy. There is also another sign in sagittal section known as the hummingbird sign. Okay. And it's a hot cross bun sign which is seen in multiple system atrophy. So these are the pathognomic signs which will give some idea. Then there are some atrophic patterns. In frontotemporal dementia, which was already dealt, you saw that the frontotemporal atrophy is there. Actually, whether it's a behavioral variant or language variant also we can get based on the pattern. Because of lack of time, I'm not going into that. Huntington's disease, you see what is known as a butterfly ventricle, wherein the caudate, which is jutting into the particular lateral ventricle, is atrophic. Okay, so this is known as Huntington's disease. Then Alzheimer's dementia, you have the typical hippocampal atrophy. And in spinocerebellar ataxias, we will have the cerebellar atrophy. Okay, and these are different white matter hyperintensities which we can also detect. Lacunar strokes is also common. Multiple sclerosis is also something we will see. Focal infarcts is also something we will see. Okay, so I am not going to much detail, maybe I'll finish in another 1 minute, is the medial atrophic score. So at bedside, when you have MRI, you can actually classify them based on the different types of atrophy into a medial temporal atrophic scale, which is known as the Shelton scale. You can all read about it. Then there is something which we, myself, Dr. Migita and all we were using is known as the Faseka scale. Then there's a parietal atrophy scale, which is the Coedam score for parietal atrophy, which can also be utilized. And then there is a global cortical atrophy scale. So all these are visual skills. A radiologist need not look at it. We only ourselves can look at the particular MRI and tell that it is global cortical atrophy grade 0 or grade 2 or grade 3. This will add lot of objectivity to what you are doing. And then there's a functional imaging which we are using in, especially in neuropsychiatric disorders. So fMRI, which is depending on a particular signal known as BOLD signal, blood oxygen level dependent signal, wherein oxyhemoglobin is diamagnetic and deoxyhemoglobin is paramagnetic. Based on this principle, we can actually get more oxyhemoglobin in the areas which is working better or being metabolism is more better there. So which we can look at to identify psychosis risk, identify people with dementia. There is another grade of studies. I think all of us would have now started looking at what is known as PET studies. Okay, so PET studies also will show us the different metabolism. For example, here Alzheimer's, there is bilateral parietal hypometabolism. The red is more metabolism, green and blue is less metabolism. FTD, it is more of frontal hypometabolism. And then application in clinical research. So there are many methods. If you are interested after your MD to pursue a research in imaging, these are some methods you will be using. That is subcortical volumetry, where each of the subcortical structures you will be looking into. Voxel-based morphometry, where the subcortical structures the computer will generate and specific softwares would be utilized. And surface-based techniques. So actually there is an Enigma consortium, which is enhancing neuroimaging genetics using meta-analysis, which is also happening at NIMHANS now. So this all will help us in identifying different forms of neuropsychiatric disorders, which has led to a new term known as psychoradiology. Okay, so if people who are free should go and read about psychoradiology. It's a term started by radiologists, not by psychiatrists. And they are telling that look at the image and then predict what psychiatric symptoms they may have, what psychiatric disorder they may have. So that is how personalized medicine and radiology is coming to. 2016, this term was introduced in a paper in American Journal of Neuroradiology. I think all of you should go back and look at psychoradiology. In the Frontiers paper, it is there. You can just go back and look at it. Okay. So with which I conclude, I have some case vignettes. Yes. So 64-year-old gentleman, okay, he comes with subacute onset illness, rapidly progressive cognitive decline with visuospatial deficits, and he is also having myoclonic jerks. HMSE is very low, 16 out of 31, and blood investigations are relatively normal. MRI show, can somebody tell what did the MRI show? And it showed some changes, okay? And it resulted in a particular rapidly progressive dementia. Okay. So who wants to answer can raise their hand and I will tell. Yes, very good. So can you tell the full form of CJD and why do you say it is CJD? Based on imaging. Yes, so this is what is known as cortical ribboning. Also there are some subcortical signs like reverse Hockey-stick sign, pulvinar sign and all, which can also be seen. But here you can see the classical cortical ribboning, especially in the FLAIR images and diffusion images. So that is very important. Okay, very good. I think there is one pen drive awardee there. Okay, then is another 70-year-old farmer from Tamil Nadu Whoever wants to answer should raise their hands, okay? Acute onset illness after fall, okay, following which he had reduced speech output, impaired comprehension as well as headache, and mild dragging of the right lower limb. Okay, he had mild right hemiparesis when examination was done. And his CT was done, and it shows this. Who wants to answer? One of you can raise your hands. We have discussed this maybe some 15-20 minutes only, this particular. First of all, is it normal or abnormal? Very good. So half of my work is done. Now you have to tell me what is the abnormality. You can attempt. The organizers are planning to give some prizes also. Yeah, please. You can. Sorry, your answer is right for another question. Note this. But you have attempted. It's good. It's a mixed density. That's where you picked it up. Good. But do you see anything else? Anybody wants to attempt? Pen drive is waiting.
Left subdural hemato.
Who told?
Sir, left subdural, chronic subdural.
Very good, very good. Correct. So left subdural hematoma. Good. It is there a very thin rim, but I am happy you were able to spot it out. At least my class has reached that level that somebody in the 10th row could answer. Very good. Thank you. Okay. So this is my last case. 14-year-old child from Dharmapuri, Tamil Nadu, South India. She presented with features of multiple seizures, and she was also having some blindness, and they had started her own anti-tuberculosis therapy thinking that it is neurotuberculosis, and then she came to the emergency with disorientation. Okay. Can anybody identify till now? No. It could be any cause of delirium, isn't it? That's what we are all thinking, post-seizure or anything. Imaging showed this. Starry sky appearance, who wants to answer? People who have got pen drive need not answer. Yeah, so who wants to answer? One of you can stand up. So this is known as starry sky appearance. But along with in the brain with multiple lesions, she also look at the muscles. Look at the trapezius muscle, the deltoid and all. There were lesions all over the body. This has been published by us already. You are right, whoever has told the answer. Yes, it's neurocysticercosis. So with this, I thank you very much for your kind attention. You really have attended. And I sincerely greet you all from Center for Brain Research, Indian Institute of Science. Thank you very much.
Thank you, Issac. It's a very excellent presentation. I think it's definitely a great learning experience for the postgraduates. Very good. Because of the paucity of time, we will only allow only 2 questions. Questions? Anybody? Okay, I'll give them.
Sir, what about this mesial temporal lobe sclerosis? We often get.
Yeah, so mesial temporal lobe sclerosis is an important condition where there is a medial temporal lobe signal changes resulting in thinning of the temporal pole. So what happens is that repeated complex partial seizures can actually cause significant kindling and resulting in dystrophic neurons. And it appears in the mesial temporal lobe region, and it is looking as a hyperintense signal, and with the body or the height of the hippocampal horn being very small. Okay, I had pictures, but because dearth of time, I am not showing it. And you actually require surgery for that. So you have to do what is known as medial temporal excision or removal of the hippocampus or the diseased part. Okay, so that is one important area for psychosurgery.
Okay, thank you. We'll wind up the session. Thank you, Issac.
On behalf of our Tirunelveli, Kanyakumari, Tuticorin and Tenkasi District Psychiatric Association, we want to honor our organizing secretary, Dr. Pannisalam, and we want to felicitate now. So it's the correct time. I think now there are a lot of people. During the validity function, everybody will be missing. So we want to honor now itself. So he is the man who worked hard behind this entire CME for last 3 months. So everything. So thank you, sir. Thank you very much for your hospitality, everything. So I request Dr. Arul Prakash, Dr. Sriram, Dr. Sabrin, Dr. Anand Krishna Kumar, sir.
Thank you, TKT colleagues. Actually, I dedicated all this shield to our TKT team itself. இது வந்து தனியாக ஒரு மட்டும் பண்ண முடியாது, எல்லாம் ஒரு கம்பைண்டாக பண்ணணும். இட்ஸ் அ டீம் ஸ்பிரிட். இவ்வளோ பெரிய நிறைய பண்ணுறோம் அப்படின்னாவே பின்னாடி பேக்ரவுண்டில் இருக்கிறதுனால தான் பண்ண முடியுது. ஏன்னா ஒரு சின்ன இது நான் சொன்ன மாதிரி இன்னாகரேஷன் சொன்ன மாதிரி வி ஸ்டார்டட் வித் 10 people. நான் வந்து இப்போ வந்து we have a 48 டிக்கெட் அசோசியேஷனில் 48 people இருக்கோம். we have done a lot of work. நிறைய ப்ரோக்ராம் பண்ணிக்கிட்டு இருக்கோம். நிறைய ஸ்டேட் லெவலில், சவுத் ஜோன் லெவல், ஸ்டேட் லெவலில் நிறைய பண்ணுறோம். பிஜிசிஎம்இ அதே மாதிரி வந்து ஆனுவல் கான்ஃபரன்சஸ்ஸு, ப்ராக்டிஸ் சிஎம்இலாம் பண்ணுறோம். இன் அடிஷன் வி ஆர் ஆல்சோ டூயிங் ஆல் இந்தியா பிஜிசி எவால்வ் சிஎம்இலாம் பண்ணியிருக்கோம். மெனி ஸ்பீக்கர் ஹூ கேம் ஹியர் இஸ் ஆல்சோ எ ஸ்பீக்கர் ஆஃப் அவர் எவால்வ். நம்ம வந்து மெயினாக பண்ணுறோம். பிகாஸ் நெகா ஹாஸ்பிட்டல் மெயினாக டிகேடி சைக்கேட்ஸ் எல்லாம் சேர்ந்து தான் நம்ம பண்ணக்கூடியது. டாக்டர் ஐசக்கு அது மாதிரி சுகாஸ்லாம் வந்திருக்கேன். தேர் ஆல் ஆல்ரெடி ஸ்போக்கன் இன் அவர் எவால்வ் சிஎம்இ. தேங்க்யூ வெரி மச். Thank you for all the TKT members, also TNIPS office. Thank you very much, sir. I'm really feeling honored and humbled. Thank you. I need a lot of your cooperation also. I'm going to be President-elect of Tamil Nadu IPS. I'm the President-elect. I'm going to take a charge in July at Chengalpattu. I need all your cooperation, guidance and support to take this IPS to the Tamil Nadu IPS to the next level. Thank you very much.